Good afternoon. Thank you very much for inviting me here to come and speak. I suppose I'm not really going to talk around any of the kind of issues that were presented by our first speaker, because actually the world has moved on quite considerably since kind of a lot of that research that was presented. What I am going to talk about is the individual placement and support approach, which is often summarized as IPS. And in essence, if you kind of remember nothing else in the next 20 minutes, the secret is all in the first 3 words of the title. It's a very individualized way of working with people. You help people by placing them into a job, and you then provide the wraparound support to enable people to make a success of that job. And it's actually no more complex than that. But in terms of our systems, in the UK, and from my experience of implementing across European countries, actually it's a seismic shift in the way our welfare services are set up, our health services are set up, our social care services, and just the way the money flows in terms of provision for vocational rehabilitation providers. What I will also say is I think I'm coming from a very different place to any of our other speakers today. I work in the National Health Service in London, southwest London. It's a catchment area for us of just over 1 million people. All the people we serve have mental health conditions, ranging from kind of common mental health conditions through to kind of other common mental health conditions, but which are much more severe and enduring in their nature. At any one time, we're serving around 16,000 people. So we're kind of a big, large beast of an organization. One of the things which over the last decade and longer that the organization has made a commitment to is recognizing that whoever we're serving, for a lot of those people, returning back to work is a key goal which they identify as part of their recovery. And so it makes good sense for us as a health organization to take that seriously and to kind of work with it, and so to support those that do want to return back to work to be able to do so. So, if I speed up, because my mother tongue is English and yours is not, and you can't keep up with me, can you just like start waving your arms and I'll slow down? Okay. What is the individual placement and support approach? It's a very direct and individualized search for competitive employment. And I think this is really, really important in the context of just some of the discussions that I've heard this morning. We're talking about normal, open, competitive employment, not subsidized jobs, not specially created jobs for special people, normal jobs that anybody can apply for in society. What it doesn't do is go through kind of lots of pre-employment preparation or pre-vocational training. Neither does it screen people in terms of, are they ready to go back to work? Or it's kind of, as we have across Europe, this kind of whole employability issue. Are they ready? Fundamentally, and this is the kind of the big issue, is it moves to a place and train approach. So we place people into jobs, specific jobs, and then provide specific support to make a success of that job. Not the other way around. We don't train people generically on how to go back to work and then hope that some of those kind of generic skills make some sense when somebody turns up at a workplace. It's not that. It's very much place and train. The OECD identified that it's evidence-based, which is pretty unique for vocational rehabilitation. So it's manualized, has a fidelity scale. You can implement it. It does raise some of those kind of challenges which you've heard this morning about, can these people really work, whoever these people are? So this assumes people can work in ordinary competitive settings. What it does do is tackle that integration issue between mental health care and employment services, bringing together those different specialisms under one roof, working together on a shared goal. And what it does do is, I think, quite helpfully move the mental health system forward in terms of kind of just focusing on the treatment outcomes, actually focusing on outcomes that matter to the individuals who use services, i.e. employment outcomes. So, as our first speaker kind of was saying, is this a realistic goal? Well, what we know from a lot of very solid, quantitative, randomized controlled trials, and it's interesting where you look, depends on your profession. If you're an economist, you look at certain literature, and if you work in the health service, you look at very different literature. And what we find is there are a huge amount of randomized controlled trials which tell us very, very clearly what works and what doesn't work. We know that things like diagnosis and symptoms do not predict success. So you may be working with somebody who has a diagnosis of depression or somebody with a diagnosis of schizophrenia. You can't actually tell by the diagnosis or how disabled they are by their symptoms who will be successful at going back to work. What we do know is the repeated predictors of success are firstly having had a job in the past, ideally in the last 5 years, but actually wanting a job, motivation, and believing you can work, that self-belief issue, are actually the best predictors. So if you're working alongside somebody who wants to go back to work and they believe they can do it, statistically, they'll make the move back into employment. I think from a health service perspective, and one of the real challenges around this issue, is the whole issue of shared decision-making. Given we know that diagnosis doesn't predict, so we don't need to do lots of work readiness or employability testing, whose decision is it actually in terms of when it's ready to go back to work? And I'd say it's not health professionals. The other issue that often comes up when talking about helping people return back to work is work is quite stressful. I don't know about you, I find it quite stressful. So therefore, if I've got a mental health condition, is that going to be helpful? Stress is all relative. And I think we have to kind of think about it and look at kind of what are we comparing it to. If you know the literature on unemployment, you know that that's incredibly stressful. Whereas if you look at the literature on employment, as long as you're in a good job, actually the stress burden outweighs itself. And there's a very, very nice paper written by Joe Marone, who was a user of mental health services, and his psychologist, Goalka, who kind of wrote about the transition from being a long-term user of mental health services and being unemployed and making the transition into the workplace with a job. And just talking about the different stresses and strains. And it's an easy paper to find, you just Google it. If you think work is stressful, try unemployment. So, the individual placement and support approach. Very much a place, then train, not train and place. There are 8 evidence-based principles. And I say under each of these different principles is a whole raft of evidence derived from now over 20 randomized controlled trials. These aren't kind of ranked in any particular order. They work in any kind of shape and guise. So the first one just starts as the primary goal is that focus on competitive employment because it just logically makes sense that if that's what people want to do, that's what our focus should be. The eligibility, as we've kind of highlighted, actually should be based on the individual's choice. If we know the predictors are motivation and self-belief, if somebody's motivated and they believe they can do it, why stop them? The aim is to support them. The third one is always one which, if there are any health professionals in the audience, I always kind of get the experience that they hear the first 2 words and then anxiety kicks in and then they don't hear anything else. Because the third one is rapid job search. And health professionals often just hear rapid job and their anxiety levels go off scale at that point. But this is about actually starting the job search within 4 weeks of entering a program. And if you think about it yourself, if you were unemployed and you went to an agency to help you to go back to work, and after kind of talking to you about what your interests are, how you want to do it, etc., nothing really happens, and after a month you kind of think, well, I need money, I need to go back to work, I want to work. Nothing's happening, what do? You'd go somewhere else. So this approach is very pragmatic. It kind of says, let's start looking for jobs and searching for them as soon as possible. The next one is actually the really, really challenging one and takes time, as has been kind of echoed by Christopher's presentation and other bits and pieces. How do you integrate the work of employment support and health support together? And on a pragmatic level, this takes time. And in my experience, even though it's highly frustrating, actually the reality is it often takes 6 to 9 months. When I know, and this is even good clinical teams that we have in our organization and in other organizations, when you embed an employment worker into that clinical culture, it takes time to build up a trust, confidence, and respect of the clinicians to really work with you. But once that happens, and they can actually see the real benefits of having an employment worker in their team, everything is then possible. and things move very, very quickly. But it does take time. Attention to client preferences, incredibly important. Folk with mental health conditions, whether it's depression or schizophrenia, no different to you and I. If you end up working in a job you don't want to work in, working the hours and days and shifts, etc., that you don't want to be doing, you would leave. People with mental health problems, ironically, are no different. They work in exactly the same way as us on this kind of issue. So it's really important that we kind of help people to get the jobs that are important and work for them in line with their preferences, etc. And with that, how one works with employers has to be based on those client preferences. There's no point trying to kind of find jobs for people in areas people aren't interested in. It doesn't help the individual, and it really doesn't help employers. Because not all, but a lot of mental health problems fluctuate, there needs to be this element of kind of the availability of time unlimited support. And if you think about the kind of three words, individual, placement, and support, how we make that support work, what it looks like, who provides it and how, is another matter. But how that time unlimited support works and is available is really, really important. And then welfare benefits counselling needs to be supported, needs to support the transition into work, and therefore calculations need to be done at a time so people actually know if they're going to go back to, if they're going to apply for a job, how much better off will they be? And people actually know exactly, euro by euro, pound by pound, krona by krona, whatever it is. But that's really, really important. Just something we haven't kind of had at all today is kind of thinking about actually what's the individualized impact of this. And here's just somebody we work with in London, kind of a young chap, 29 years old, diagnosed with schizophrenia. And he kind of says, when I met with the employment specialist in the clinical team, he asked me what I wanted to do. He advised me to focus on what I really wanted to do, as it would be good for my health. He then helped me with all aspects, such as interview preparation, job searching, and contacting employers. He arranged an interview with a care organisation and helped me prepare for this. I was then offered a job, which I'm very pleased about. I'm now 31, and this is my first real job. I'm a healthcare support worker, and my employment specialist supports me and my employer. So just bringing that kind of sense that behind all of that, you can hear and get a feel for those different principles that we've just been through, actually just how they kind of operationalize and just play out on a day-to-day basis. If we look at the kind of hard research evidence, here are 16 of the many randomized controlled trials published. And what you see is the kind of the black lines are the IPS approach, the individual placement to support approach, and then the red and the orange are the control services. And you can kind of just by, without having to take too much of a glance at it, you can kind of see that over and over again, the IPS approach is far more successful than the control services. And the control services are normally train and place in their kind of nature. And you can just see the kind of the marked impact. And if you think about it in terms of effect sizes, you've got 2 to 3 times the effect size going on here from hard research trials. Hard research trials are good. There is a further one, which I take, I think this is the first Scandinavian trial, which I worked on over in Malmo. So it's only over the bridge, go and see them. And, this was quite interesting because they got the grant, and then the day they were starting the study, Malmo and that wider part of southern Sweden went into recession. Fascinating. And so here we go, and you can kind of see, in terms of people going back to work, under IPS, 46% of people went back to work versus 11%. And in fact, the IPS participants gained jobs 5 times quicker than those in the local vocational services. There was good fidelity to the IPS approach, but there were huge implementation challenges. Huge. I mean, things to an Englishman just don't make sense at all. A social insurance system that kind of says, because people haven't gone through all their processes and procedures and ticked every one of their boxes, but an employer wants to give them a job. And the social insurance system saying, no, they can't take the job because they haven't ticked all these boxes, seems to me somewhat perverse and bizarre. Maybe somebody can help. I worked on this trial for 3 years, and we kept coming across this kind of like really strange behavior within public services. Maybe somebody can help me at lunchtime to understand it. I'm sure it's nothing like that in Denmark. It can be a bit like that in England, but not as bad as in Sweden. Okay. In the real world, randomized controlled trials are great, but in the real world, what actually happens? Here's work when we started to implement this approach within our teams, and the black solid line you see is the employment rate. And this is kind of working across 4 community mental health teams. And we did a kind of staged implementation because I was shutting a sheltered workshop, which was releasing the money to put into employment specialists for IPS. So you have a kind of stepped approach to implementation. By the time you have the one employment specialist in a community mental health team, it's operating to high fidelity, and that's where you really see the numbers of people returning back to work. The kind of heavier dotted line is people in mainstream education and training. And you see that grows, but not at the kind of same extent. And then the whole issue around work experience and voluntary work. Again, that's the kind of like the slightly dotted line, much lower down. What's the impact? When we looked at it at a kind of borough level, which is like a municipal kind of level, we looked at kind of what was the impact on the employment rate for folk with mental health problems using our services, and we went from 12% to 21% in open employment. Again, we were shutting a sheltered workshop, so 5% of that population were in sheltered work, and by the end of it, it was down, in 2006, it was down to 0. But we'd had a marked increase in the number of people returning back to work. People always say, yes, but how many hours were these people working? And we looked at that, and it ranged from 4 to 42 hours. The average amount of hours people was working was 28 hours per week. This is something which is quite close to my heart. This is young people with a first episode of psychosis. And I think this is a group, a population of very young people right on that transition point into kind of adulthood who get struck down by psychosis. And here we have kind of tracking people for 2 years as they came into contact with our services. And we looked at it in terms of when people came in, only 12%, the blue line, were in employment. But 6 months, this is an acute psychosis, first psychosis. But by 6 months, 35% were back at work. 12 months, 42% were back at work. 18 months, which carried through to the 12-month mark, 48% back at work. And we spoke about that early intervention and kind of moving quickly with things. And this is a really, really good example here where actually within a very short space in time of people being very, very ill, they've been able to make that transition back to work. There are challenges. I think I'm not going to labor on them. We have and if I think of it from an English kind of context, we have the health service, we have social services, social care, and we have the welfare system. We've got the myths, which have been kind of bouncing around in one shape or guise this morning. Can these folk with severe mental health problems actually work? If they do, won't it be rather stressful and cause a relapse? And sometimes you find the health system taking a very different perspective, kind of saying, isn't our job to protect the public and the individual from folk with mental health problems? What we're talking about here with IPS is kind of actually integrating these 3 systems. What we have to move from is a kind of system where the health service focuses still on treatment and cure. We have to kind of move from social services being the kind of caring for those people who have failed by the health service and provide that support to those folk. And then the welfare services who make, and I can only speak for England, and I think it gets echoed all over the place, some very strange judgments about whether people can work or not, in complete isolation to the health service and social care service. The IPS approach is a paradigm shift. It forces these things to come together and have to work together. That's echoing what I've already just said. There are some wider challenges. Something that's not been mentioned, I don't think, this morning, is the whole issue around stigma and discrimination. In England, we've had a stigma and discrimination program running since 2003. Every year it gets more and more money. But yet, we have kind of huge incidences every year where issues like this in a tabloid newspaper a report gets published, and all of a sudden it gets sensationalized, misinterpreted, and 1,200 people killed by mental patients. Shock 10-year toll exposes care crisis. Not a reality if you read the report, but it sells papers and sticks in the mind of employers and the general public. Last Halloween, and we just had it again this Halloween. Last Halloween, you could buy, in some of our massive supermarkets, your psycho patient outfit. Because it's, after all, it's what everybody wants to do for Halloween, isn't it? Dress up as a psycho patient. It's obvious. As you can see, not only does it come full with blood stain, you also get your meat cleaver as well. It's a bargain for £20. That's what, 25, 27 euros? Who wouldn't buy one? Stigma, prejudice, discrimination, live and well. We have to acknowledge it, we have to work with it, we have to tackle it. Clinicians' attitudes, as a result of some of those societal stigmatization issues, it has a knock-on effect for clinicians. Globally, they think it's a disgrace. Many, many more people with mental health conditions should be working. Then you kind of ask them about their own caseloads. That's different. Very disabled. Work wouldn't be good for them. And here, this is a London study. 2/3 believe caseloads are either incapable of working, or if they were able to work, only be able to do voluntary work or sheltered work. So again, attitudes that we need to kind of bring together and kind of work out and make some sense of, to kind of look at, actually, how do we make this work? We just finished a study which was published in the summer, a randomized trial, kind of to look at actually whether, if we provided clinicians with training in relation to motivational interviewing to address this ambivalence around whether people can work or can't work, actually whether it would improve client outcomes. So the aim really was to kind of train clinicians to kind of work through their own ambivalence around, is it right to help somebody back to work or not? And you can kind of just see, it was a small study, it was a feasibility study, had a massive impact. 6 months, 33% had gone back to work instead of 12%, and by 12 months, 65% had gone back to work rather than 38%. This is for young people and conducted during our recession in the UK. So, implementation obstacles. The sentences provide you with the obstacles, but if you read the green text, it gives you the sense of what you need to do to move forward. Focus on that early intervention. Adopt the evidence-based practice. Focus on work resumption. That's for kind of health colleagues. Integrate the service. Case management. Make it a priority for clinicians, and interagency cooperation. These are the kind of things that come out over and over again, whether it's in England or any other European country I've worked in. Here's the kind of benefit, and again, I was on the ward for 3 months. I was prescribed risperidone tablets. Other patients told me not to take them, but I decided I would. After a while, the psychiatrist said it was okay, and I should think about going back to work. Can I just check you're all awake? In the Danish system, a show of hands if you think the psychiatrists, it's common practice for them to kind of say, I think you're okay, and I think you should consider going back to work. Just a show of hands if you think that's a kind of common practice in day-to-day practice within psychiatry in Denmark. A couple of ambivalent people. Not even one show of a hand. It shows the challenge that we have in terms of integration. Anyway, I met regularly with my employment specialist to look for work and practice my interview skills. I got a job and enjoy it. Been there 9 months now. My routine at the moment is great. I feel healthy, happy, positive. I play football once a week when my team is doing well. I see both the doctor and the employment specialist. I feel positive about the future, and I've set myself several goals. For example, I'd love to go on holiday, as I've never been abroad. I think that's what it's actually about in terms of what we're trying to do and improve people's lives, and again, move from disability to ability. Thank you very much.